Did you know that hormone therapy was the very first targeted cancer treatment? We asked Dr. Sean Fanning to tell us more about why hormone therapy works so well to treat some breast cancers.
So the significance of estrogen receptor in breast cancer is that 70 to 80% of breast cancer patients will have an overexpression of estrogen receptor in their tumors. That means that these tumors make more estrogen receptor than normal tissues. That means this presents us an opportunity to therapeutically target this protein that is critical for the development and pathology of breast cancer.
There are currently three main types of hormone therapies that are FDA approved to treat breast cancer. Dr. Fanning explained to us how they work.
So an aromatase inhibitor will function to starve the receptor of the endogenous estrogens that would fuel the breast cancer. Whereas a molecule like tamoxifen, which is called a selective estrogen receptor modulator, binds to the estrogen receptor where estrogen would normally bind. And in doing so, it essentially reprograms the estrogen receptor to, rather than being pathogenic like it would if estrogen is bound, it now has therapeutic activities. SERDs are termed selective estrogen receptor degraders. They'll further change the shape and the dynamic character of the receptor in such a way that the cell says, oh, this protein is not properly folded anymore. And when that happens, the cell has mechanisms in place called proteasomal degradation that basically acts as a garbage dump for any protein that's not properly folded. And what SERDs do is they take advantage of this native machinery of the cell and say, okay, get rid of the estrogen receptor everywhere.
To learn more about how the estrogen receptor and hormone therapies work in breast cancer, check out our video linked below. Fulvestrant was the first FDA-approved SERD, and it's been used to treat metastatic estrogen receptor-positive breast cancer since 2002. Researchers have been working hard to identify and develop additional SERDs since then, and the first new SERD since fulvestrant, called elacestrant, was just approved in 2023. We asked Dr. Fanning why there is so much interest in developing new SERDs.
So fulvestrant, within, let's say, a cultured cellular system, for example, works beautifully. That's because it's very potent, it's very effective. The issue with fulvestrant comes when you need to give it to a patient. And that's simply because in terms of pharmaceutical profiles, it is so poor that it can't be given as a pill. And rather, it has to be given as a painful intramuscular injection into the glutes. And so this was kind of the first real need for an oral SERD, was to develop something that's simply pharmaceutically better and easier on the patient.
Dr. Fanning also explained that another promise of SERDs is overcoming treatment resistance, which can result after long-term treatment with tamoxifen and aromatase inhibitors.
One way to really think about cancer and how it progresses is that it's genetically unstable and it's a rapid evolution, if you will. And so that's the advantage that cancer cells have and tumors have, is that they're always evolving and they're always changing and adapting to their environments. And so in the terms of, a typical patient who's undergoing hormone therapy, they might have this selective pressure, if you will, of a hormone therapy for 5 to 15 years. And hopefully, in the course of the surgery, radiation, and potentially chemotherapy, that these tumors have been effectively taken care of. And this is also the case for the adjuvant hormone therapies, where hopefully all this is being taken care of. But if there's enough of a tumor burden going in, that these tumors can maybe just kind of go dormant while under the hormone therapy, then they get this selective little genetic instability such that they can evolve ways to get around being sensitive to the hormone therapy.
To learn more about treatment resistance, check out our video linked below.